Good morning, everyone. It's so good to see so many familiar and happy faces this morning. So thank you all for coming. Um, and this transition from COVID to normality, I'm just excited that we are meeting in person again. Next slide. Um, so we moved our neurology clinic from third floor to second floor, the same building, UPMB building. Next slide. But it's not about buildings, it's about the people working with us. And I'm so glad working with these folks. These are the most committed folks that I ever work with. They started working on this conference almost six months ago. So of course, our beloved nurses, Natasha and Casey, and from the department side, Kayla and Christy, and also Dalton's. We missed David a lot. He would always sit in front of this conference and with his, of course, with his happy face. But we are glad that Patsy is here with us. Then Kristen, Kyra, and Black, they work really hard. As I mentioned, almost 6 months ago, they started working on this conference. But I want to tell you guys about my mentors, Betty Marsh and Don Nunes, who I learned so much over the period of time, and they are my true mentors. So thank you, everyone. Thank you, everyone, for making this conference great. Next slide. So we will discuss deep brain stimulation and what exactly it is. So we will go over those W questions: what, who, when, why, all those things. But in very simple words, DBS is, you guys can think about of it as a pacemaker of the brain. So we have pacemaker for the heart, and this is a pacemaker for brain. So if you guys look at it, there is this lead going into the brain, then we seal that, and this battery, if you look at it in the chest, we implant it in the chest or abdomen, and then with the extension wire, we connect the battery with the lead. Now, it can be done, so it's a two-stage surgery. The first stage is putting this lead in the brain, and the second one is putting this battery, IPG, in the chest or belly. We can do it too, under MRI guidance or MER, meaning micro electrode recording that we will be doing in clinic, in OR, I'm sorry. And in the MER guided one, usually the patient is awake. And of course, the doctor is also awake. But in the MR guided one, the patient is asleep. Now we have the availability of only MER guided one here. Next slide. Now, in order to go over anything, I think it's wise to go over the historical perspective of it. So surgery for Parkinson's disease is not something new. People have been doing it almost a century ago. When they started resecting those different tracts. But then they figure out that by making a dent in those tracts, it can lead to side effects like weakness, balance issues, sensory issues, all those problems. So fast forward, there was this neurosurgeon in France who was doing this in, I think, late 80s, when he was trying to localize the brain areas, and he gave a little bit of electric current to those basal ganglia region, And that was the aha moment, and that actually gave birth to deep brain stimulation. Next slide. But when we look at the what we call ablative procedures versus deep brain stimulation. So ablative procedure mean you kind of put a dent in that area and kill those neurons, versus deep brain stimulation, when you just put this lead in there, that type structure that I showed you guys, and stimulate that area. So what's the difference between these two is that one is reversible, and that is deep brain stimulation. What do I mean by that? So meaning that, let's say if you are developing any side effect like speech issues, dysarthria, balance issues, sensory issues, weakness, contraction of muscles, then we either change the lead or go over those stimulation parameter or shut the device off. So it's a kind of reversible, right? Next slide. Now, in order to go over the DBS, I think it will be wise to go over the medication, especially this carbidopa, levodopa, and also about the disease. So as Dr. Bulu rightly mentioned, this the go-to medication actually is this carbidopa, levodopa. But you guys know about the half-life of this medication? It's just 90 minutes. So it means in 90 minutes, the medication is cut into half. It's actually, if it is without this carbidopa, it's 50 minutes. Now, about the disease, Dr. Bulu mentioned about those prodromal stages when REM behavior disorder happens, those dream enactments, and anosmia, hyposmia, meaning there is problem in the sense of smell, constipation, or mood issues. And then the clinical stage starts, meaning the tremor, stiffness, slowness, walking, talking, all those issues. Now, initially, when we give the medication, this carbidopa, levodopa, it lasts for somewhere around 6 to 8 hours because of the buffering capacity of the brain. But then, as the disease advances, or I would say with the duration of the disease, what happens is those motor fluctuation and dyskinesia start. What do I mean by that? That you would need more of the medication and more frequent. And you guys might have heard about those fancy words like when we discuss in clinic, wearing off or delayed on, or early morning symptoms like early morning akinesia, dystonia, or failure to on. But in very simple words, what exactly is off period? Off period is a clinical stage in the patient with Parkinson disease when the motor and non-motor symptom appear or worsen, leading to functional disabilities. So what are the motor offs? Tremor, stiffness, slowness, walking, talking, difficulty getting out of the bed, chair. What are the non-motor offs? Non-motor off also come, and that is called those dopamine dysregulation syndrome. So neuropsychiatric wise, anxiety, depression, panic attack, apathy, loss of attention, concentration. They usually go to bathroom so frequently that urinary urgency come, bloating come, pain come, and worsening restless leg. So those we call those features motor fluctuation, and of course dyskinesia is part of that too. Next slide. Now, if you guys look at it, how DBS works, so there is loss of dopamine. Dopamine is not the only chemical responsible for Parkinson's disease, but for the sake of simplicity, it's the lack of dopamine that leads to all those features of, especially motoric features of Parkinson's disease. So if there is lack of dopamine, there are those dysfunctional circuits then, right? So what deep brain stimulation do, that electric current is just create a white noise kind of situation and reboot those circuits again and again and again. And that lead to those improvement in motoric features. Next slide. So I'll give you the tale of 3 dash dash dash. So as Dr. Barron mentioned, so we are 3 movement disorder neurologists, we would be. So Dr. Malik, me, and Dr. Richmond, 3 neurosurgeon, Dr. Norregard, and I think a lot of you guys been implanted by him. Dr. Euclid, I don't know how many people know this neurosurgeon. He's one of the famous neurosurgeon in the Midwest. And Dr. Kandu is also joining. 3 commercial product with us: Medtronic, Abbott, and Boston Scientific. And I must tell you that the folks that we work there with these companies, whenever I call them or my patient call them, that never went to the voicemail. So they are that much committed. And I appreciate all their commitment and everything they do for our patient. And the third one is 3 targets in the brain for Parkinson's disease. So always, if you guys don't remember anything from this talk, the tale of 3, remember that. Next slide. So I'm glad that we have 3 commercial products, because now it's more and more healthy competition. So they are making those devices smarter. Not only the battery from non-rechargeable to rechargeable, meaning, so non-rechargeable battery would last for 4 to 5 years, but the rechargeable one lasts from 15 to 25 years. And they are also making the lead even smarter. So lead is just like my finger. So it's a circular lead. And now we can actually activate part of that. So that is called directional stimulation. Why would we do that? Because if there are issues there with the spread of and spillage of electric current, then that can help us. They are also making the devices smarter in the sense that we would soon have this adaptive neurostimulation, meaning when you have symptoms, then the DBS would start working, not 24/7. And so many other things coming to this field. Next slide. So this is that lead. So 1, 2, 3, and actually Medtronic also have the directional lead. So see the second and third one, the middle one are usually the directional one. And all 3 of these commercial products have this availability now. Next slide. And this is the battery, that rechargeable one and non-rechargeable one that is available with us. Next slide. And this is when a neurologist become like an engineer also and design how much the strength of electric current needs to be and what should be the shape of that electric field, so that we can give the patient more benefit and less or no side effect actually. Next slide. It's FDA approved for Parkinson's disease and essential tremor. For dystonia and OCD, it comes under this HD exemption. What does that mean is humanitarian device exemption. So if there are less than 4,000 surgeries per year for dystonia or OCD, then FDA usually would give you a green signal and it is covered by your insurance then. But epilepsy, MS tremor, and so many other indications are coming. Next slide. This is the most important slide. Like, who would be the candidate for this surgery? Not everyone. So if someone having the established criteria for Parkinson's disease, so Parkinson's disease could be of 2 types, right? Tremor predominant or the postural instability gait disorder one. It is not for atypical Parkinsonism like multiple system atrophy, Lewy body dementia, PSP, or corticobasal syndrome. In fact, it can lead to worsening of those diseases. So it's just for a typical Parkinson's disease. Now, previously, the disease duration was longer than 5 years, but FDA actually went down on that. Now you would be able to be a candidate for this surgery if your disease duration is more than 4 years. I've seen people being implanted way earlier than this, but when I see any case scenario like this, I'm concerned about any progressive kind of Parkinsonism, like those atypical, or if there is any diagnostic discrepancy, meaning that the disease was there for a long time but wasn't being reported. Now, those motor fluctuation and dyskinesia, we discussed that, and quality of life and social functioning influenced by levodopa responsive sign. What's the exclusion one? If somebody has a terminal illness, then let's say if we do this surgery, we can improve the motoric features there, but it won't affect the quality of life. But there is one exception, and that is the palliative course of, or the palliative indication for DBS is also coming in the field. And in fact, I implanted 2 patients who has really bothersome dyskinesia. They were wheelchair bound, and the dyskinesia was that bad that the therapist and the family member have to strap them to the wheelchair. So we implanted those 2 cases with really good improvement. But as I mentioned that, they have other issues also, but it's usually when we see anything like this, it's a major surgery, so we try to avoid that. Then another absolute contraindication is dementia. And that's why we take the help from our neuropsychologist, Dr. Eric Hart. And almost all of my patients, I never implant before he gave me a green signal. So I'm looking for his evaluation, and he will be the next one to present. So we are lucky that he's amongst us. Now, these other 2 criteria, depression and psychosis, these are soft signs, because let's say if these are caused by your medication, then with DBS we can do medication reduction, and the depression and psychosis become a soft sign. Then, of course, excellent levodopa response. So you guys, when you come to our clinic, we do off medication and on medication exam. You guys might have seen that. And if it is more than 30% motoric improvement, then there's one thing. The only one caveat is medication-resistant tremor. The tremor would always respond to deep brain stimulation, provided the lead is placed in the right place. Then patient motivation, and that's why we are arranging these seminar and these conferences to motivate you guys. Because what if it is something that will change your life? As I mentioned, it's not for everyone, but for selected patient with Parkinson's disease, it makes a huge difference. Now, this one situation, this realistic expectation, I want to elaborate on that with any intervention, you guys need to have realistic expectation. If you guys have too low expectation or too much expectation, usually there is what we call after those DBS implantation, those post-DBS blue, meaning more issues with mood and of course with everything. So whenever you guys go to any doctor, but especially to movement disorder clinic, you guys need to have 3 to 5 most bothersome symptoms. And let's say when your neurologist examine you and that matches and you guys get on the same page, then of course it would benefit you if your problem list actually would be helped by deep brain stimulation. Now this caretaker support and family member support, I think in Midwest we are not too much concerned, because every time I see my patient, there is good family support. And stay tuned for Patsy lecture also. Next slide. There is another criteria we sometimes use, and that is 5-to-1 criteria, meaning if patient is taking more than 5 times per day oral levodopa, more than 2 hours per day of off times, or more than 1 hour per day of those troublesome dyskinesia, then some centers usually consider it as a indication for invasive strategies like deep brain stimulation, levodopa therapy, or levodopa pump, or those other pumps also coming. There was subcutaneous carbidopa levodopa pump is coming, and also the subcutaneous apomorphine pump. Next slide. Now, with any major surgery, there is risk of bleeding, infection, stroke, all those things. This was a patient actually who I called our clinic on Monday, and she was saying that the battery, something is sticking out of her chest, and we saw her in clinic, and then it was the erosion in the skin, and she went for urgent IPG implantation. Next slide. Now, we are lucky that we have that multidisciplinary approach for Parkinson's disease patient care, although it's at different places. But what does that mean is that we have neuropsychologists, we have a neurosurgeon, we have neurologists, we have therapists, physical therapists, occupational therapists, speech therapists, psychiatrists for psychiatry evaluation. But we are bringing it under one roof, and that's our goal. And that will make it more patient-centric, meaning the patient would be the sun, and we all would revolve around that patient. And that's the best model. Right now we are doing it, but at different station. But that's our goal. Now, when we implant a patient, we usually do the DBS programming 4 to 10 weeks after implantation. And it's because of that swelling around that lead that is called honeymoon period. But just like typical honeymoon, that won't last forever. And the effect usually go away, and then you guys come and we do the off medication, off stimulation exam, then off medication, on stimulation, and on medication and on stimulation. Next slide. But the role of medication is always there. So it's always some stimulations, some levodopa, and some therapies, and there you go. Now, the three targets that we have is they are the VIM, STN, and GPI. Next slide. Now, these are deeper structure in the brain, that basal ganglia that we are talking about, and some presenter talk about it as a basement in the brain. And just like in any basement, mysterious structure lies, right? So here also, if you look at it, this deeper nuclei, thalamus, there's a target for Parkinson's disease and also for essential tremor, mostly for essential tremor. But we use it for Parkinson's disease, especially if tremor is the only feature. So I have 3 or 4 patients that I implanted VIM because it carries less issues with cognition and less issues with balance and other things. And that's why it's amenable for ablation also. And by ablation, I mean focus ultrasound or radiosurgery or any of those things. There's a fun fact, and that is in neurology clinic, the demographics are different. You guys would be considered young if you are less than 75 years. If you are beyond, I'm sorry, but so why the age is so important there? Because when we look at those sites, like even above 70, 75, we still can do deep brain stimulation surgery. Next slide. Now, this other side, the STN, subthalamic nucleus. This is a very small nucleus in the brain, but very powerful. And it has a lot of connection with cognition and limbic system and so many other systems. And that's why, it's powerful, but above 70, 75, we are a little bit hesitant because it can cause cognitive issues, mood problem, autonomic issues, freezing of gait, and sometimes balance issues also. So DBS, yes, and I think around the world, this is the target that we use the most, but it's not for any ablation therapies. So focus ultrasound, those other, I think studies are coming, but I think there are more issues, more side effect with this side. The good thing about this side is more medication reduction. So almost 50% or even more than that. But as I mentioned, I always keep my patient on a little bit, just like one tablet 3 times a day of carbidopa, levodopa. But with this one, it says some dyskinetic, dystonic, also that we can use it for those conditions also, especially for dystonia. New research is coming. Next slide. But so this is important, that when we are in the OR, we can see that stimulating certain area of brain can make our patient cry or laugh. And that's important because with those mood issues and all those things, whether there would be role of deep brain stimulation and work in progress. It hasn't achieved the FDA status, but that's cool, right? That we can stimulate the brain and can help our patient with those mood issues. And that's why you guys need to be nice to your doctor also, because he can make you laugh or cry. Next slide. The last target is this nucleus, we call it GPI, globus pallidus internus. And this is a deep structure in the brain that have what we call anti-dyskinetic properties. That when we stimulate that, so let's say if somebody has a lot of dyskinesia, just like I mentioned some of my patients that we did it literally for palliative care. So we implanted the GPI because it's a very safe target. It's a big nucleus with less side effect, and we can do it about 70, 75, and it is also up there for ablative therapies like those focus ultrasound or other therapy, and we call it that procedure pallidotomy. So for thalamus, it was thalamotomy. For GPI, pallidotomy. Next slide. So all those target works. Next slide. Now, you guys remove my fur babies. That's not cool. That's not cool. So just getting back to deep brain stimulation, when you guys select the right patient population, select the right brain area, those target, and the right center, I think it can make a huge difference, especially for tremor. And I wish I would be allowed to present some of my videos, that how much, like from this much tremor, if it is down to this, what else we want for our patient. And that's why it's always a good idea to discuss those options. I know it's brain surgery, but if it can make a big difference in your life, I would advise it for my family members. And that's why it's always a good idea to go over these with an open mind. Thank you so much for coming.